you for subscribing to the Frequency-Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Kim-Pettis.
How are you?
I am fantastic.
You look like glowing. What happened? What did you do? You did something really fun, I can tell.
I did.
What?
I have a little backstory to tell you.
Okay.
And people who know our guests that we've had know and have heard of the name Peter Twist that we've had him on. He is our Canadian movement guru. I cut my teeth as a trainer with his training programs. And what was always really interesting about Peter Twist is his philosophy was, I have to teach athletes how to stop before I can teach them how to go.
That's interesting.
Yes. So I'm going to say that again. He wanted people to learn deceleration, how to stop under control before he would ever teach them how to start. And as we know, most athletic injuries occur during deceleration, except for our Olympic sprinters that will pull a hamstring during a sprint. But for the most part, we see the sprained ankles, the ACLs, it's all during a deceleration mechanic. And his philosophy wasn't about strength and it wasn't about flexibility. It was all based on proprioception.
Yeah.
And those of you who know my sports courses and the rehab component, and part of the big smile on my face is putting those courses together and adding those exercises. And I don't even like to use the word exercise. I'll say movement pattern, because we all move. And I understand a bit of the pushback with sports course because it's not sports related, it's movement based, whether you're a professional athlete or an octogenarian that just wants to.
If you're not able to move correctly because of injury or disability or whatever, and you start moving, what you are doing is rehabilitating.
Correct.
So that's why it's the rehab course.
That's right.
There we go.
And when I undertake a new challenge, I get really excited about it and I want to do it and I want to do it well. But I think we've talked about this almost in every podcast. You don't know what you don't know until you don't know it.
You know it.
And so putting these slides together and putting these courses together reminded me of a course that I started during COVID. And I am not one to start things and not finish it, but this was a course I had started and not finished because the course was based on fascial line training. So thinking about fascial lines and not as just things to elongate, but that fascia is innervated and that matrix can, I hesitate to use the word contract, but
as the muscles contract, the fascia has to follow.
Exactly.
Yeah.
So this matrix of ebbing and flowing, contract, relax with the muscle, and movement within the fascia has to be thought of when we start doing these fascial line exercises. So the last component of the course was to invent or design a exercise based on fascial lines. And you had to videotape, you had to explain the exercise, explain the purpose. You have to execute the exercise while instructing it, and then have somebody do the exercise. So it's not just explaining the exercise, it's executing it and having that exercise be reproducible.
That's fair. And you know what it went through my head as you were talking about that? Is that whether you're accelerating or let's say decelerating, for every concentric contraction, there is an eccentric contraction that has to control and balance it.
That's right.
So did I get it? Do I
You
get
get a gold,
chocolate?
you get a gold star and a piece of chocolate, because we talk about eccentric contraction under load being very, very good for proprioception, good for that myotendinous junction, the joint capsule. So we use a lot of.
It is shown to, eccentric contraction is shown to repair it's the only way to repair the Achilles tendon besides FSM, is eccentric contraction. And describing to somebody like me who had an Achilles tendon tear how to eccentrically contract, that was very confusing. But yes, go.
And I have a purpose to this whole
Okay.
story. So it took me forever to come up with this exercise because it's Peter Twist and I have to make him proud. So it's not like just taking some course that some robot is going to look at my exercise and check a box. I know he is going to look at this exercise, and
Oh dear.
him for so long. I want to make him proud, just like presenting the sports course to you was. It took me probably 20 times longer than it should have if it wasn't you. I wanted to make you proud. I wanted this.
Always have been.
I take pride in what I do, and I think that this just blew it up. So I had this exercise and I wanted to send it to 3 trainers that I think are the world's best trainers that I've had the privilege of working with. And I said, hey, I took this course and I came up with this exercise and I have this video.
What do you think?
Tell me what you think. And the one trainer I was so nervous about, who I do think he's the absolute best in the world, did this unbelievable 3-minute recording of how great he thought the exercise was and gave me some constructive feedback in such a polite and respectful manner to make it even better. And it just prompted a day-long conversation about movement and safety. And that is why I love fascial line training. This is the movement pattern that I don't want to say I invented it, but I'm pretty sure I invented it. And the reason why I love it is because it should feel safe and good. And there's so many modifications that you could make. If you had a dislocated shoulder, if you had a knee pathology, if you had an ankle pathology, and it just made my heart explode that what was in my head was actually true. When you have that validation, and you and I have this all the time, you're like, I ran that, and you have a hypothesis and you try it and it works. And it's like when it works, and then it just works so well. And you can't wait to.
Yay.
So when it's done, I will absolutely share it, that and better edited video of it. But what makes me just so happy is that the best of the best, the trainers are talking about the principles that I hold so deep in my heart. And now that these 2 rehab courses are almost at completion, the basement membrane of the course is movement has to feel safe.
Fair enough.
And what science and our data is showing is that if the movement doesn't feel safe, the repair is not happening. So this is what the day-long conversation from these different trainers and I had today was, sometimes you will see a shoulder rehab. Let's just say it's a dislocation or a labrum tear or something that is non-surgical, that it should
partial thickness infraspinatus and teres.
Right. So let's just say that's our person, and they're going through PT and not getting any better. The pain is not subsiding. The range of motion is not improving. Strength is not improving. And then we get an MRI and we look and they say, that's weird because everything looks good in here. I don't know why it's still hurting. I don't know why it's not getting strong. That is the component. These are the people that find me and find FSM. And that is, I think, that is why 40 and 89 came into my life, is because they weren't consciously afraid to move, but there was a component in that loop, that feedback loop of injury and compensation and motor control shutdown and compensation and new injury. There was a part of that loop.
And there's a piece of that FSM is capable of doing that allows the midbrain to feel safe.
Yeah.
Challenge with partial thickness, infraspinatus, supraspinatus, teres, partial thickness tears, people think that the tear is the problem.
Right.
And the problem is that the subscapular nerve is scarred down to the subscapularis muscle. And you can do anything you want. The muscle, the teres and the infraspinatus are all healed, and the brain is not going to let it move as long as this nerve is scarred. So even for us, you can run 40 and 89 all you want. But if you haven't dealt with adhesions in the subscapular nerve,
Right.
the brain is going to go, yeah, no, nerve is to protect the nerves.
And that concept of the nerve is adhered, we're never going to move a scarred nerve. That concept is that first part of the shoulder rehab model. Is you have to check, these are certain boxes that must be checked. And so sometimes we integrate corrective exercise way too soon because there are those adhesions there. And I understand we want range of motion and we want things to move, but there are checkpoints in place for a reason. So I just think, because I deal a lot with the FSM community and practitioners, sometimes I second guess, is this just working, or am I just getting this feedback because I'm in this bubble of practitioners? And then when I expand my communication to people who don't know anything about FSM, and I talk about what we do without the numbers, of course, and they're like, that is absolutely what has to happen. But how can we do this? I'm like, oh, we do this because we do this with FSM.
We do this with FSM.
And the other component I wanted to mention that we get to utilize, and we talk about it, is how does this look when this is gone? The hope part, the excitement part, the happiness part. Because if it is just a exercise, if it is just an appointment that you have to go to, if it is something that causes pain, that is going to stall recovery and rehabilitation. Yeah. So the relationship that I get to have with the people that work with me, that when I hear feedback of, oh, this is the best part of my week. Yes.
Yeah.
Even though.
What other rehab can you go to where you leave with your endorphins 10 times what they were when you walked in the door? Not only does it not hurt as much, I mean, it's a little uncomfortable, yeah, but you get stoned besides, and it's all good. And there's no other kind of rehab PT that does what we do.
I have a snippet of a thank you card that I want to read also, because I feel like I'm just spreading joy and happiness today. And I want to I'm not going to read who it's from or the details of the person that I'm working with, but there's something important about the thank you note that I'd like to share. We so enjoy our visit with you, the warm, friendly family feel. We appreciate the benefits we've experienced with FSM in your capable hands. And then quoting me, oh, that was easy. Quote, mission accomplished. After other doctors and therapies have failed, or after being told there's nothing you can do about it. We're both so grateful for your caring, kindness, and help.
There are stacks of those on,
I'm sure,
shelves in your office, my office.
But and it's not like to toot my own horn or anything, but the fact that this person feels my hands are capable, that was the first thing that kind of struck me. I feel capable, but it has to feel that coming from the provider, from the practitioner. And there are absolutely conditions and treatments where you're just like, I have no idea where to start. I don't know if I am even close to getting my A channel or B channel where it needs to be. but taking a breath and knowing, okay, I know enough that I'm pretty sure I can make a dent in this. And saying to somebody, there's nothing you can do about that. That really bothers me. I don't know what, I can't think of any condition that there is always something you can do. Maybe it doesn't cure it. Maybe it doesn't cure it in a day, but you can make somebody's life a little bit better.
It's nothing wrong with palliative care. Oh, and I have a story too.
Okay, sorry. I know I came flying in. I came right from the clinic here because it was just one of
your hat on and everything. And and you're so excited. It's just so cool.
I am so excited. I am so excited about these exercises and this way of thinking, and it's going to be amazing. So thank you for letting me share what I needed to share and get off my chest. And now I can sit back and listen.
I'm excited about the rehab course because FSM has finally grown up to the point where we get to, hi, Derek, where we get to move to the next level, where it's like it's taken us 30 years to get the basics organized. I didn't figure out how to teach this until about 8 years ago. And then you came up with a sports course 10 years ago. And yes, it was for sports, but it was about 2 years ago that you and I decided what really needs to be rehab. And then it was about a year and some odd ago that we said, we really can't, you really have to do the upper and lower body. Are they ready? Our FSM community, are they ready? And when you see how excited they are, and they're ready, but it took this long to build a foundation of confidence and knowledge. And it's always in sales, we used to say it's the 20% of your customers that do 80% of your work. So it's the top 20% of our practitioners who come back and redo the core, who come back and do the advanced, and who will come to the rehab course. And speaking of people that have no hope, I have to tell you about what I did yesterday.
Let's hear it.
Actually, Monday and Tuesday. The patient is 74, came in all sort of stooped over on a cane, barely able to walk. His pain diagram was both shoulders, both arms, both legs, and his low back. And he said, well, I had my first discectomy infusion in 1990. And then I had a laminectomy in 94. So that was a long time ago. And he said things really didn't get bad until about 3 years ago. What happened 3 years ago? I had a 3-level fusion in my neck because they'd done one fusion before and then they decided that, so they did foraminotomies and they did a discectomy infusion at 4, 5, 5, 6, and 6, 7. And as he's sitting in the chair, his whole upper body is going like clonic movements, uncontrollable, spastic movements, can barely move his legs. And he said, my wrists are really stiff and it's hard to hold a pen. And I said, I have to use this little pokey wheel. So I just did the basics and it was hyper numb, really hyper ick. And so it was mostly 6 and 7. And he had his had his left shoulder replaced by a doctor where it was the first or second time she'd ever done a shoulder replacement. And she didn't do a reverse. She did a regular, which nobody does anymore. And the next surgery they want to do is his other shoulder. And so basically, he had 3 surgeries, the one on his neck, 1, 2 on his low back. Oh no, the one on his neck, the shoulder replacement was 3 months after his neck surgery, and then his low back. And this is nerve pain. I can treat nerve pain. And the spasticity part of this is got to be 81 and 10. So one of his daughter came in and her best friend came in. The best friend is a student who's going to be a nurse practitioner. And she's taken, between the two of them, they own 4 custom cares. And so we ran around his neck and down his arm, just from the elbow to the hand. And then from neck to feet, 40 and 10, because you look at the whole pain diagram amplified. 81 and 10 to stop the clonic movement. And then from his low back, because not only did they do a discectomy and fusion, someplace along the line, he had a laminectomy. That's a good face. So we did low back to feet, just reduce inflammation in the nerve, which 40 and 396 in our language. So I had 1, 2, 3, 4, 5 or 6 machines. 1, 2. I had to do one because he can't put his hands together. So we had 1 machine on each arm, 1 machine from his low back to both feet, 2 machines from his neck to both feet. So that's 1, 2, 3, 4, 5. And the 2 girls they're in their 40s, so they're girls. The 2 girls looked at themselves and said, we need 2 more custom cares. And at the end of it, his pain was no longer an 8. It was a 2. But his head was still like this, down,
So people who are listening, you're flexing.
So he's looking down all the time. So the second day when he came in, his pain was a 5, but only on one arm. And his shoulders hurt. That's a C4 nerve root. And there's cord compression. He's got stenosis at C4. So that C4 nerve root is cranky. And he said they want to replace my other shoulder. And I said, that'll improve the movement if they do it right. But your left shoulder doesn't hurt because the shoulder needs, because of the arthritis. It hurts because it's a C4 nerve root.
Right.
Oh, why? And then what goes through his head, or what somebody said, was, why didn't anybody else say that? And I said, because they don't have a way to treat it if it's nerve pain.
Right.
So we treated neck to arms, and this time I ran from C4 down to his hands, 2 machines. I didn't have to treat his cord because the clonus never came back. Treated his low back and his legs. And then I did the supine cervical practicum on the occiput, C1, C2, C3, 4. So if you fuse 4, 5, 5, 6, and 6, 7, there's going to be a disc bulge at 3, 4. The level above goes if you fuse everything below it. So we ran disc repair on his neck, and then by hand, I took apart the scar tissue at the base of his skull, the nerves at the base of the occipital nerve, and then I did the supine cervical practicum, the dura, the facet joints at 4, 5, and all the scar tissue in the joint capsule. And he's 74, so hardening in the capsule and the periosteum and all that. And then he leaned his head back. And this all comes back to movement. So now, instead of, the reason his head was forward all the time was that the upper cervical facets were so painful that he couldn't put his head in neutral. I didn't want him to look up. I just wanted him to be able to see straight ahead. So, we treated scarring in the vagus, scarring in the nerves, and when his pain was a zero everywhere, including his shoulders, got him up. He got dressed. I used my little activator at C1 and C2 and got his rotation to 45 degrees, because that's the only thing that isn't fused is the occiput C1 and C2. First 45 degrees of motion. So he could rotate 45 degrees for the first time in probably 5 years. And I said, now I want you to stand up. And he stood up and he looked down. And I said, here's your cane. And because he could now keep his eyes level and look straight ahead, we had to make his cane longer because he was no longer bent forward. So he's looking straight ahead. And we practiced walking. Can you feel your feet? Yeah. I said, okay, then look straight ahead. And I grabbed his belt from the back, and the girls just touched his elbow. Look ahead, feel your feet. No, look straight ahead. His gait changed, his cane level changed. He had no body pain, and his legs could move because the nerves didn't hurt.
Yeah.
It wasn't arthritis in his knees. It was nerve pain.
Yep.
And getting the facets in his upper neck to not need, that's why his head was down, was that he had to gap the facets. So when you treat the facets, you get his head in neutral. Then I said, now I want your nose horizontal. You don't know where your chin is, but you know where your nose is. I want your nose horizontal. Tuck your chin a little bit. And he went, oh. I said, now shift your weight to the right, shift your weight to the left. And that's the safety part. I'd already run 40 and 89, but you can't do that when they're standing up.
Right.
And the brain will stop being afraid once it finds out that it can walk up 20 feet to the end of the room. And we did that almost 10 times. So you can walk 100 feet without falling over, looking straight ahead, find horizon, and you have to tell them how to walk again and get all the proprioceptors saying, what? How? Okay. And that was the high spot of my day yesterday.
And that's just pain-free movement. I don't want to say just, but that is always the goal, is some sort of integration of active movement following treatment that's going to, in my opinion, and science and my thesis that's 30 years old says
Everybody.
that you need to have that component of movement for long-term results. You can't just ply somebody off the table and send them out the door without integration of that, because those are the people that get their pain returns a day later or by the time they get to the car for the most part.
Well, in his case, it would have been dangerous. His facets didn't hurt, but he didn't know how to walk.
Sure.
Because in 5 or more years, he hadn't walked with his eyes horizontal. He's 6'3", even at 70.
Wow.
6'1" at 74. So you could watch the proprioception integrate in the brain without messing with FSM, because the brain will do it on its own, but it just takes time. And walk more slowly, feel your feet, look straight ahead, and depend on proprioception. I
Right.
didn't call it proprioception. Feel your muscles, feel
Yeah.
your butt, feel your feet. And it's like the exact thing you're talking about. They have to move when we create such huge changes in pain, in
Range of motion.
joint function, tissue texture, tissue tone,
Yeah.
muscle tone.
Yeah.
And without 81, I told him the spasticity was going to come back. Nobody knows how long 81 and 10 is going to last because he's got cord compression at C4. But so that was the highest spot of my yesterday.
And that's the best part of my day. The reason why I was just so excited is I was able to geek out for hours about safety and movement and quality of movement. And that should be the goal for every practitioner that's listening. Your goal should always be to get that person to move better.
The power of proprioception is a good phrase.
It is huge because that is especially for vulnerable joints like the shoulder and hip, highly movable, are very vulnerable. Like that is just biomechanically how they are structured. So going back to an example of the shoulder, two things I wanted to pick apart what you were saying. There are so many people that come in with shoulder pain and I am taking a look at their neck and they're like, why are you looking at my neck? My neck is fine. I'm like, it's not. You can't rotate to the left. The imaging that you brought along with your file shows that you have compression, stenosis, a disc. That is why your 3 years at PT didn't do anything to your shoulder, because I think your shoulder is actually not the problem. And then they look at you like what you were saying, why has nobody mentioned this?
And they want to replace his shoulder. And I said, it won't do any good because you have C4 nerve pain and that's why your shoulder hurts. Your shoulder will move better, but it won't stop hurting.
But for sure on imaging, a 74-year-old shoulder is going to show something. So that seems to be like how people, why they think surgery is the way to go, because that the image will show some degeneration. It's like, of course, almost every 74-year-old shoulder is going to show degeneration, especially if you were athletic. Same thing with so many things that we see on imaging. It doesn't always mean just because the image is bad doesn't mean that's causing the pain and the pathology. It's worth asking more questions. It's worth doing your exam. It's worth creating a FSM hypothesis and trying. If I run something on the facet, something on the disc, something on the cord, does this change the pain? And if it does, you are on the right track somewhere.
And treating, because we are the only ones that can treat the nerve successfully and the cord successfully.
And the dura, right? And so I had talked about a patient a while ago, and I'd actually sent you the MRI of her neck, and somebody who's got quote unquote frozen shoulder, who has just a trash neck and like 30 years of history of neck pain, headaches, vertigo, jaw pain. It all makes sense that it's not coming from the shoulder. Treating the shoulder sometimes makes the pain worse. And when we treat the dura, when we treat the stenosis, when we treat the cord, the pain gets better. It makes sense why PT and those types of things don't work. However, sometimes it takes some time. Like a neck that has that type of degeneration, that type of stenosis it doesn't seem to last that long. And that's where the discussion comes into play. Listen, you're pain free for 2 days after you see me, after we treat the dura and the cord. Maybe it's time to get a custom care and treat yourself at home. And now the trajectory is going towards, I'm going to try shockwave on my shoulder because that might help. And you let them try. I'll never prohibit anybody from trying something. But what I wanted to say too, as a practitioner, if you run into those cases, I have found it's better to step away. So I always say, I'm going to remove myself from the treatment plan right now while you explore these other options. Because I know it's not going to make anything better. And I think too, for the patients that are listening, it's really hard to figure out like what's working if you're doing 10 different modalities in 1 week. Or if you get worse, it's really hard to say, okay, that made it worse. And getting worse isn't a bad thing. It's education. I would rather make somebody way worse in a short period of time than make no change at all.
Oh, any outcome is information.
Absolutely. And
Yeah.
I think we get scared about that. So when someone says, I actually felt a bit worse after I saw you, I'm like, okay, great. Can you explain that? And they're like, why are you so happy that I was worse? And I said, because this is information and this is going to help me tailor today's treatment or tomorrow's treatment or
Tells
your
us what to
homework.
do. Yeah.
Exactly. We have been rambling a lot. I see that I don't know if we just got a question, but I was just alerted to it.
This is the first question.
Okay.
We had a practicum weekend for people that had taken the course on video this last weekend. And it was supine cervical 3 times, and then supine neck and shoulder once, and then the supine lumbar. And there was psoas and ureter on every table when there was that practicum, and the difference it makes in low back pain, not just because the psoas refers to the low back, but when the psoas is tight, it compresses both discs and facets. So if you see a lumbar MRI that has disc bulges at L3, L4, and facet degeneration all the way down, you go start with the psoas. And that was watching the light bulbs go off in that class there was like 13, 14 people there. So it was a small group, only 3 tables. And it just was so much fun watching them get excited about what they could do and watching them actually get it because they just watched the video. They'd never had their hands on people, with 1 or 2 exceptions. And then getting their hands, and that's what teaches you what the frequencies do. So exciting. All right.
I have a couple things to mention with this question, but let's read it and then for people who
Okay.
are listening. There's a 52-year-old male client with a history of, you know what, actually, I'm going to let you read this because I hear a dog barking. I'm going to mute myself really quick.
Okay.
Go ahead.
I have a 52-year-old male client with a history of many concussions due to sports injuries, one of which was a baseball to the left temporal, geez, that knocked him out and left him with a massive black eye. He told me this story after he was on the table being treated. He has constant vertigo, that he has learned to live with. He also has mild PVCs that he started noticing in the last couple of years that have become more bothersome. Ran concussion in Vegas, vagal tone, heart health on him while working separately on a bad shoulder. When he got off the table, his vertigo was worse, 94 and 94. I hoped it was just the usual woozy feeling that will get better in a few minutes. I asked his wife a couple of weeks later, how was he doing? She said his vertigo was really bad for a few days and that he just didn't feel good. The concerning part is that his PVCs were worse and have not gotten better in the last month since treatment. I only treated him the 1 time, but I'm thinking that he has a vestibular injury. And that's the thing. When you have a patient where the history includes getting hit in the head or being unconscious or multiple concussions, part of your physical exam has to be a vestibular screen. And part of your history has to be a BIVSS. And we had a patient come in this last week whose one of his major complaints was dizziness. And I said, when you're sitting still, is the room moving around you? No. Is the room sitting still and you're spinning? No. So you're not that's dizziness, is when one of either you or the room are spinning. what could you describe what you have as a sense of not knowing where you are in space? What he had was severe disequilibrium, and his BIVSS score was 71 out of 18. And then in the practicum, we always pass out BIVSS scores, forms. And the doctor who brought him to see me, her score was 56 out of 18, and she had no idea because you get used to it. But Klein, your problems started right there with the history. You never run 94 and 94 on somebody that has had multiple concussions or that has constant vertigo. For sure, they have a vestibular injury. Just take 94 and 94 out. That's why he was worse. PVCs are worse. That's a guess, but if the vertigo was really bad, the vagus nerve thinks he's dying, and that might be a problem. Also, the sympathetics get jacked up, and that could make the PVCs worse.
PVC is premature ventricular contraction.
Yeah, it's like the heart is cattywampus.
Yeah.
It's not beating in rhythm, premature. The ventricles contract before they should, and you feel it as a ka-thump thump in your chest instead of where not knowing where your heart is. Okay, Thad is respectfully disagreeing.
Yes. And okay, Tad, I'm not saying that everybody's 74-year-old shoulders will look clean. I'm saying a lot of, if we all had even asymptomatic joints could show things, is what I'm getting at. So,
And his imaging does show that the doctor described it as bone on bone, but not with an MRI, with an X-ray. The shoulder always looks like bone on bone when it's with an X-ray. And the problem with the pain in his shoulder is nerve pain. So I said, so you can get your shoulder replaced, but it will improve the range of motion. It's not going to change the pain.
correct.
And
Yeah, all I wanted to say is that pathology and imaging it's not always congruent. We can have extreme pain in joints that on imaging look completely normal. And we can have no pain whatsoever. And then something is found incidentally. And you're just like, how are you actually walking right now? Because you don't have X, Y, or Z. That was only my point, was to not, it doesn't always make sense. And Tad, that's amazing that you are as functional and as healthy. And we should all hope that we are like
you
that.
don't even look 74.
No.
But the other piece of it is that you will have people with spine imaging where the degeneration is minimal and the facet pain is awful. And you have spine imaging where the degeneration is awful.
Yeah.
And there's almost no pain. And the guy wants to know, is it okay if I go play golf again tomorrow? And when you look it up in the literature, the difference is whether they heal with inflammation or without inflammation, whether the repair tissue is inflammatory or not inflammatory.
Yeah.
Derek.
So I hope that made sense.
I think it did.
Okay.
I think, and yay, Tad, you can touch your fingers together behind your back, lower yourself to a 4, rise back up. You're in good shape. You get extra points. Yay.
Yes.
And he's one of our speakers at the Advanced on N of 1 statistics. The challenge when you have a patient that it's an N of 1. You're doing a single case report, and reviewers like statistics, and that is going to talk about how to do statistics on that.
And I think that's really valuable, because I think a lot of the practitioners think, oh, it was only once, or it's anecdotal evidence. Evidence is evidence. And especially when you can write it up and then it happens again, sometimes 6 months down the line, you're like, oh, I saw this and this happened and I'm doing it again. So I think it's very important to hear that there is so much value for that N of one.
Yeah, and that you can turn it into a number.
Right.
That N of one statistics will have either a t-score or p-value. I don't know what he's going to talk about in statistics, but that's a thing. I had one of those, is this going to help moments. Got a call for a recovering stroke patient, went in not knowing where to start. Client started telling her story, which guided my fingers to plug in the frequency pairs, and I left with a feeling of, did I do the right thing? 2 days later, I received a call and was told it was the best treatment she's had in a while, and it really helped. There you go. I like
That's
patients.
that. Okay, good, because I have so much more to talk about.
Okay.
I always run out of time. So I want to just go back to stenosis for a minute and the cord and the referral to the shoulder and what can help and the longevity of it. I have been getting some pretty substantial long-term results with an N of 4 right now,
Yeah.
running congestion in the cord and congestion in the dura with stenosis.
That's a good idea. I ran straight up 40, but I turned the current down to 100. I set it at a gentle wave slope, and everything I did on him was alternating and just did inflammation. And
and that is what I always start with, because that is just what I know to help with pain quickly. And again, treating the pain is absolutely the paramount. That is what needs to happen, because you're not going to have somebody, even if you know this treatment's going to take an hour and a half and they are in pain, don't make them wait an hour to get out of pain. Get them out of pain first, because again, nothing will feel safe if they're in this painful pattern on the table.
But congestion makes sense when you think about it. But in order to not be congested, it has to be not inflamed. There's a reason that the sequence is 30, 40, 50.
Right. Yes.
40 comes before 50, but using them together or at the same time or one and then the other, that makes perfect sense.
Yeah, like I've never done it in isolation, running just 50, like I said, because I know 40 to be helpful for pain. So
that's a good idea. It's like the inflammation in the cord, when you see a disc bulge pressing on the spinal cord, it's pressing on the dura too, right?
Yeah.
Because the disc is on this side of the dura. And the explaining to somebody that the disc is a jelly donut and it's not herniated, but it's bulged. That means there's 14 layers of donut, and there's 7 of those or 8 of those 14 layers are cracked. And the jelly is like battery acid, and it just leaks through the little cracks, and then it inflames things, and that causes pain. And I don't know, food analogies always seem to work for people. Anthropomorphizing the nervous system, where the brain tells the cerebellum and the cerebellum tells the muscles, and then the thalamus says, no, you're not, or the hippocampus says, no, you're not, and the cerebellum says, I can, and the hippocampus says, no, it's not safe. And then if we tell the hippocampus, yeah, it's safe, really, I promise, here, just chill. And then, anyway.
So that conversation, those conversations that happen, it's helpful for patient education, but it's also helpful just as a practitioner to walk you through the steps of what's happening, because you may have the best hypothesis, this is inflamed, but what does that mean? What does that mean for the surrounding structures? What does that mean for the nervous system? And take, for example, bone marrow edema. Exquisitely painful. It was the reason why My daughter had shoulder pain after she dislocated it. FSM was always what would help. My kids all know run to the FSM machine before they would run to anything else in the house. Drugs, heat, ice. No, get the machine going. I don't know what I'm running, but it's going to help. And she was so upset that it wasn't helping. And I had to watch back my colleague, who we will see, Dr. Reynolds, going through the MRI with me. And then she's got some bone marrow edema here. And I'm like, bone marrow edema. I have not treated bone marrow edema.
So what did you use? Like 40 and
14.
238?
14.
14? It must be from the advanced for edema?
It is Bencatholi. Thank you so much for bringing that to my attention. And I think it only works with 238.
Okay.
I have never run it on any other tissue at any other time. And maybe I could try it, but 40 would always be what I was running. And so I just so happened to be texting him about something unrelated. And I said, hey, bone marrow edema. And I was actually asking him for bone marrow as opposed to, because I was running inflammation in the bone. I was running inflammation in the periosteum. I understand the mechanism of a shoulder that dislocates. She had a Hill-Sachs. She had a Bankart lesion. I was treating all of those areas. The pain was not going down. So there's certain structures, I think, mind being inflamed, and the bone is one of them, right?
Oh, yeah.
The bone marrow, like that structure, there's no space. If there's pressure in there, that should not happen. It's not like muscle tissue that we can get a little bit of a pump in our bicep and that gets inflamed and it's not a threat. It's not a big deal. Bone marrow is a bit of a different
And
story.
using 40 in the bone marrow makes me nervous.
For sure.
The bone marrow does a lot of things, and quieting inflammation or quieting the activity of the bone marrow, probably not a great idea. But 14, edema in the bone marrow.
Yes. And that is, I was like, I don't know. And I think 14, I'm just pulling it up on my buddy really fast. It's edema, but it's also appendicular skeleton joints, upper body. So maybe it's like one of a 2-for-1 deal.
I don't know.
I don't know either.
I'm going with 14 as edema.
Yeah, absolutely. And like I said, I've only ever used it in that bone marrow edema like situation.
Sweet. Okay, that goes in the advanced.
I also tried 284 as well, because I thought like deep old bruise in that situation, it helped a little bit, but nothing to write home to. But it was finally, it's running a blinded trial where I'm like, I never overpromise. I try to actually underpromise and overdeliver when it comes to everything. So it was one of those cases of, I'm not sure this is going to work. Let's try this. And it was like relief at last. Thank you, Mom. What took you so long for figuring this
Figure it
out?
out? Yeah. What is it? Be realistic, expect a miracle, but be patient. The impossible takes slightly longer than the difficult.
Yes.
There's that.
Yeah.
Yeah.
And so, yeah, there's all these little nuggets and stories that everybody gets to share at the advanced. So again, we're just going to be giving everybody gentle reminders for the early bird special, and get yourself to that, because there's going to be a lot of fun networking.
Rheumatoid arthritis patient with a lot of shoulder pain ended up running scarring in the bone marrow, and the pain went from a 6 down to a 2 in just a few minutes. When I had my hip replaced, we could not get my TFL to relax and my quadriceps to relax. And the massage therapist was an FSM practitioner, and she ran scarring in the bone marrow, and the muscles all turned to smush.
Wow.
Yeah.
Like you said, sometimes we have to think about, when it comes to 40 and 81, if I take down the inflammation or quiet the activity of X, Y, and Z, what would that mean? Or if I'm going to if I have the potential to increase secretions here, what would that mean? And that's what guides me to, that's a great question. What would that look like? what could,
If it works, if I do what I think I'm going to do, what will happen? That's the first do no harm question. That's why we don't run increased secretions in the kidney.
right?
That's because or increased secretions in the bone marrow. What happens if it works? It's a very good question.
Yeah.
Yay.
Yay for us. What a quick hour. Thank you for, like I said, just letting me go on my happiness bubble for a little
I just couldn't not. I've
That
never
would have been
seen
cruel.
you come in so just bursting
Yeah,
with joy.
I love it. I really just love learning and putting it together and sharing and collaborating, and just so grateful for the people that we have in this community and outside the community that we're bringing into the community, because they can't
It's like the word is spreading in ways that 30 years ago I would never have thought possible.
Yeah.
And somebody said, why should I take FSM? And I just started laughing. I said, because it's the most fun you'll ever have in practice.
Yeah.
It's to be able to do what appears to be magic.
Oh yeah, Cindy, I've got some great news coming up. The FSM rehab course will be CEU approved. So we're just working on the logistics right now of how many hours and how that looks.
It depends on what state. The challenge for everybody listening, the challenge with continuing education units for every profession except for MDs and DOs, I think, every state is different. And we would have to hire a separate full-time person to do CEUs. But massage therapists, most states for massage therapists will take a certificate that you took this course and it's within your scope, and you get credit for that. That is true for chiropractors in a number of states.
Yeah, you can challenge it. Sometimes you'll need the instructor CV and the syllabus, which we provide. But yeah, the rehab course it is getting audited right now for PTs, ATs, DCs, and RMTs throughout the United States and Canada.
Tell me how you found organization that
does that for us.
CEUs for DCs for the whole country.
Yeah, that can be a separate podcast, or
No, that's an email between you and me tonight, please.
Yeah.
Because we've been working on this for 20, 30 years, and every state is different.
Correct. Yeah.
So if you found somebody that'll do all 50 states for DCs and all those people, then we'll do that for the FSM course.
I have the information.
Say again?
I said I have it.
You have it?
Kevin and I had a good conversation about it.
Oh, goody. Kevin has it. That means I can't give Kevin any more to do, but we'll figure it out.
Yes, that's exactly it. Kevin's at capacity. All right, everybody. I think hopefully we answered everybody's questions. I just saw a couple things pop up, but
no, I think we got them.
Good. All right.
All right. We'll see you next week.
I will be here. Yes.
Oh, and acupuncturists. Yes, we do.
Okay. Yes.
Yeah, we've had acupuncture credits nationwide for years.
Yes.
Yeah. So we're good.
All
Enjoy,
right.
you guys. Do good things.
See you next week.
See you next week. Oh, no, you won't.
Just kidding.
We're in Chicago at ACRM.
We won't be here next week.
We won't be here next week.
Maybe I will. Stay tuned if I can make it happen. All right.
There you go.
I'll update the email.
Take care.
Bye.
Have fun. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.